Hello, we are still in our series of disorders of the respiratory tract, and in today's class, we will discuss some of the congenital abnormalities of the upper respiratory tract. Before we dive into some of these conditions, first, let's look at some facts of the respiratory tract in children. At birth, the lungs have the same number of conducting airways. For example, the number of bronchial divisions is same as adults, though they are smaller. The number of alveoli present is also fewer, about 1/3 to 1/2 of the total number in adults. And lung growth occurs by increasing the number of alveoli and their size, and also by increasing the size of the airways. It's also important to understand that children are prone to obstruction because of a smaller airway. In infants, the intercostal muscles are underdeveloped, and for this reason, they predominantly use diaphragmatic breathing rather than the intercostal muscles. And diaphragmatic breathing, this is where the abdominal muscles and the diaphragm are engaged during breathing. As far as the ribs are concerned, they lie more horizontally and do not contribute as much to expansion of their chests. Their rib cage is less bony than in adults and is therefore more compliant, and this can also make them more prone to respiratory difficulties. Congenital abnormalities of the respiratory tract are rare, and anatomically they can be divided into abnormalities of the upper airways, that is the larynx and above, and abnormalities of the lower respiratory airways. So in today's class, we will start with congenital abnormalities of the upper respiratory tract, a condition known as choanal atresia. Choanal atresia is a narrowing or blockage of the nasal airway by membranous or bony tissue. Let's briefly visit the anatomy of the nasal cavity. The choana is a space in the posterior nasal aperture. These are two openings found at the back of the nasal passage between the nasal cavity and the throat. It is thought to result from persistence of the membrane between the nasal and oral cavities during fetal development. It can be classified in the following ways. 1. It can be complete or partial. When there is blockage, it's considered to be complete, and when there is narrowing, it is considered to be partial. It can also be bilateral, affecting both, or it can be unilateral. It can also be classified in relation to the tissue that is causing obstruction as bony or membranous. The newborn is considered to be an obligate not breather, meaning it must breathe through its nose, and in fact the only time an infant does not breathe through its nose is when it's crying. Bilateral choanal atresia, which is an emergency, causes acute breathing problems and cyanosis soon after birth. The cyanosis is typically relieved when the baby cries. You can remember by this statement that the baby is blue when it is feeding. Blue represents cyanosis, and pink when it's crying. So the baby is blue when it is feeding and pink when it cries. So crying allows some air to get into the oral cavity, relieving the cyanosis, and the baby becomes pink, and pink is a good color. There can also be persistent thick nasal secretions. How do we make a diagnosis of choanal atresia? The diagnosis may be suggested by the following: history of the baby turning pink when crying and blue on feeding, failure to pass an nasogastric tube down the nose is also an indication that there is an obstruction in the nasal cavity that's not letting the NG tube pass through. And nasal endoscopy and a CT scan of the choanal area can help indicate precisely the existence of the atresia and its severity. On the epidemiology, this is the most common congenital anomaly of the nasal cavity. And in terms of gender, females are more than males, and it is more commonly unilateral. If you compare the right side with the left side, it is more commonly right-sided, and in terms of the tissue that's causing obstruction, it's more commonly bony than membranous. Approximately 47% of children with choanal atresia can have other congenital abnormalities. The Church Association, in which there are 7 main types of abnormalities. C stands for coloboma, H stands for heart defects, A stands for atresia, the one that we are discussing today. R stands for retardation, both mentally and growth. G stands for genital anomaly, and E stands for ear anomaly and deafness. This is an association caused by a developmental defect involving the midline structures of the body, specifically affecting the craniofacial structures. Children need to have abnormalities of at least 4 out of the 7 organs to have the Church Association. The severity of the abnormalities can vary. Therefore, a child with choanal abnormalities should be examined carefully and investigated to look for these features. How do we treat choanal atresia? Treatment is primarily surgical. If it's a membrane which is causing the obstruction, a surgical procedure is done by perforating the atresia to create a nasopharyngeal airway. And if it's a bone which is causing the obstruction, it's done via drilling the bone and inserting a stent. Now let me give you a clinical case scenario related to the condition we discussed previously. So it's just a summary. XYZ, 2 days old, male, born via SVD, cried immediately, had an Apgar score of 8 out of 10, 9 out of 10, admitted to ICU, who presented with difficulty in breathing and cyanotic spells since birth. The symptoms are exaggerated by feeding and relieved by crying and mouth opening. There is history of inability to pass nasal catheter. On examination, the respiratory rate is 66 beats per minute, and there are supraesternal, intercostal, and subcostal recession. What's your differential diagnosis? How will you confirm your diagnosis? Which emergency management will you give? And what's your definitive management? Try to answer these questions to test how far you have understood the lecture. Thanks for watching.